Nice center.
Yeah. All right, guys. Thanks for showing up. Appreciate it. Some of you are voluntold. I appreciate that too. Got a paramedic class in the back there. So, Dr. Jeffrey Gibbs is going to be talking about burns today, coming all the way from St. B's. So pay attention and enjoy yourselves. And thank you, sir. Appreciate it very much.
Yep. All right. So can everybody hear me okay? Yep. Okay. So this lecture is basically a condensed version of the Advanced Burn Life Support course. Basically kind of the stuff that EMS and ER docs would need to know at facilities that don't take care of burns. You know, how do you get them stabilized? How do you package them up and get them somewhere that's going to be definitive care? So just a couple updates for St. Vincent's. I know our marketing team doesn't like to advertise, so I'd like to update people on what we've been up to at 86th Street. So currently, you know, at our facility, we're adult level 1 trauma, peds level 1 trauma. We had our consultative visit from the ABA for adult and pediatric burns last February and passed. So now we're going to go for a full verification this summer for adult and pediatric burns. So basically what I tell people is there's no injury, trauma, burn, age, size, anything that you can't bring to our front doorstep, and we'll take care of it. You know, I think everyone around the state does a good job of taking care of burns, doing trauma. I think one of the selling points for our facility is everything is housed together. Our burn center is a mixed adult and pediatric burn center. So if you have a family in a house fire or a car accident, you can put the whole family in a unit together. I've had 2 sets since we've opened up. It's worked very well. Our PICU is right down the hall, and our trauma neuro unit is the other way. So if you had a family in a car accident, again, they don't have to be split up and go to different facilities. They're all kind of on the same floor together. So that's what I consider one of the big selling points for our facility. If anybody's listening who's, you know, ER provider anywhere, the other thing we have that is a burn app, which basically allows ER docs or NPs or PAs to send me pictures. It's HIPAA compliant. You can download it on your Apple phone or Android phone. It's free to use, and basically what it does is you put some basic information in, take pictures, send them to me. It goes directly to my phone. By the time you call the transfer line, I'll already seen the pictures, so we can discuss what's going on with that burn, and that's actually very helpful as far as not over or under triaging. So, you know, there's a lot of phone calls I get in the evening where I'm like, yeah, that doesn't need to come today. That can just be wrapped up and go to clinic, and it helps on not driving in the middle of the night. So just some things we have to try and help people, you know, identify what to do with these burn patients. It's definitely not something that is as frequent as broken bones, so people aren't always comfortable looking at it. As far as transfer guidelines for the American Burn Association, this was updated about a year ago. Basically, the bigger update on this is they used to say partial thickness burns, less than 10%, can be treated anywhere. Now they're recommending that at some point they see somebody who does burns, a burn provider. Basically, that has more to do with trying to get things healed up appropriately, and also if there's scarring, to deal with scarring on the back end. As far as burns go, it's not as common as, say, broken bones, but it's definitely a significant morbidity and mortality on the population. Most of these injuries occur around the house. Some occur about 10% at work, 10% things like car accidents. More prevalent in the male population than females. And as far as mechanism of injury, it's typically in our younger pediatric population. Skull burns are the most likely cause. And as you transition into the teenage years and adults, then you're talking more flame, thermal contact type injuries. Our pediatric patients under 5 are still our most vulnerable population when it comes to fire-related deaths at house fires. And now a lot of that is ability to get out of the house. So, you know, one of the things I tell people is prevention is the best medicine. So having escape plans from the house, providing, you know, or talking about safe cooking spaces in the kitchen, which is basically keep the kids out of the kitchen when you're cooking, things like that. That helps to cut down on these types of injuries. Current recommendations for fluids from the field to the trauma bay through your primary service survey through the ABLS course is 125 mLs an hour of lactated ringers for children 5 and under. For children 6 to 12, it's 250, and for 13 and up, it's 500. So any patient that you come up on scene that you see that looks like it could be ballpark 20% burn or more, this is what you would start your fluids at. Doesn't matter how much they weigh. You don't have to get into all those calculations. All you need to do is start the fluids at this rate, and that's enough to basically keep them hydrated as they're going into a facility and through the primary survey. And the goal with that is to give them some fluids, but not give them too much fluids, because as we'll talk about later, there are bad things that happens when you give too little and bad things that happen when you give too much fluid to a patient. As far as pain and sedation, typically we use things like morphine, fentanyl, very commonly used. They can be reversed. We tend to lean maybe on fentanyl a little bit more in the burn centers because a little less histamine release, a little less itching for patients. Versed and Ativan are good sedatives that can be reversed. The kind of first line recommendation for sedatives right now through the ABA is Precedex. Tends not to bottom your pressure out as more. I also like ketamine a lot, with these patients who are third spacing fluid actively after a burn. Things like propofol and Ativan Versed tend to drop the pressures more. Ketamine and Precedex, not so much. So I think those are good things to give these patients on the front end. And as far as route of administration, it's preferred to give it IV or IO. IM, you have variable onset depending on how much perfusion is in that wound bed when you're giving it to those patients. As far as assessment goes, biggest thing I tell people is get over the way it looks, right? Everyone gets hung up on, this looks really bad, what are we going to do? If you just follow your ABCDEs of trauma, you're going to hit all the important points for burn care. So airway, easiest way to assess an airway. What's your name? Tell me how this happened. You got any medical problems? What's your allergies? If they can speak clearly to you, that airway is intact. Now, that's not to say that over time it may not change, but at that point in time, that airway is intact and they don't need to be intubated. Now, if they're hoarse or stridorous or, hey, I'm short of breath, okay, they probably need to be intubated. From a ventilation standpoint, things we look for, equal chest rise. We want to make sure that the patients are easy to bag. So if you're having difficulty bagging a patient or you have them on a vent and the peak pressures are up, it could be that if they have a circumferential torso burn, that skin that has been burned is not allowing the chest wall to expand, and you may need escharotomies done to do that. And when you do that, what will happen is it'll get easier to bag the patient, or the peak pressures in the ventilator will start coming down because it's not taking as much force to drive each breath in. Other things when you're dealing with pediatric patients, you want to remember that tracheas in children are very short, so it doesn't take much to mainstem an airway, especially if the face is all burned up and you're trying to use something to tape to the face. It can slide around and move on you. So in those instances, using something like trach ties to tie around the tube and go around the neck and around the back of the head will help secure your airway a little bit better. And you're also going to have issues with pediatric patients because usually their airways are more anterior, so it's a little bit harder to see. And usually the narrowest point is right at the cricoid cartilage as compared to adults, where it's usually at the cords. As far as circulation goes in your patients, the thing to remember is burn patients don't bleed. If you have bleeding, you need to look for some other traumatic injury. And trauma takes precedence over the burn. There's kind of that golden hour of trauma where if they're hemorrhaging, you want to get it stopped. A burn patient will eventually get hypotensive on you, but it's a slower process over a couple hours where they slowly start third spacing fluids and they get hypovolemic. So if we don't start those resuscitations going, then you're going to end up, with a patient who starts getting behind, but it's not the same. They're not losing the same volume that a trauma patient is who's bleeding actively. So it's not uncommon for a burn patient to have an elevated heart rate, but normal blood pressure, right? Catecholamine surge, they just got burned, they're tachycardic, but usually their pressures are okay for a while until they slowly start coming down. As far as access goes, 2 large bore IVs. If you can put the IVs in areas that are not burned, that's great. If you don't have any access other than where it is burned, then put it through the burn. Because the reality is if they come to the hospital and they have no access and I got to put a line in and it's burned, I'm putting the line right through the burn because I need to get access and need to get fluid started. And again, the fluid rate field to the trauma bay through your primary survey for 5 and under, 125, 6 to 12, 250, and then 13 and up is 500. LR is recommended because when we give massive amounts of fluids and it's normal saline, they get hyperchloremic on the back end. But if you don't have LR, that's fine. It's better to start some isotonic fluid than to not start fluids because you don't have LR. So start them on normal saline. When they get to the hospital, then convert them over to LR because then they're going to get liters and liters more, and that'll prevent them from getting hyperchloremic on the back end. As far as disability goes, typically for a burn patient, we use the AFU method. It's simple. You can use GCS. GCS is more more accurate, then basically we'll deal with, people with head injuries as well. It's more definitive, but for burn patients, generally just awake, alert, responds to verbal stimuli, responds to painful stimuli, unresponsive. Exposure. So this is one that I tend to harp on a little bit. So big thing is stop the burning process. If they have anything on that's still hot, you want to get it off. Cotton tends to burn away pretty clean and at a lower temperature, but some of the synthetic stuff we have in our clothes nowadays tends to stick on like shrink wrap. So getting that stuff off. If they have chemicals on them, getting those chemicals off, the sooner the chemicals are off, the more tissue you're going to salvage. Because the longer the chemicals sit there, the more it's just going to burn. Other things, jewelry, rings, that kind of stuff, get them off right away because things are going to swell. And then the big thing is keeping them warm. When you burn your skin, you lose your ability to regulate your temperature. So these patients tend to get cold pretty quickly. And you have to also remember, like, how many people are going to uncover that patient in the trauma bay to, like, do their assessment, you know what I mean? Or sometimes they're in the trauma bay and then someone doesn't put the blankets back on them. And before you know it, they're getting pretty cold on you. So really want to make sure that when you're not assessing the patient, you pile some blankets on them. And from my standpoint, you don't need to do dressings, clean sheets, warm blankets. That's fine. Because when you get to the burn center, we're going to scrub them down from head to toe. So just keep them warm, keep them wrapped up. When you get to the hospital, that's when you're going to get through your primary survey, your secondary survey. You're going to get your history, head to toe survey on them. You're going to get your pre-burn weight. You're going to determine how big the burn is, get all your lines and x-rays, all your accessory stuff in your secondary survey. So how do we determine a percentage burn? There's the rule of nines, so everything's some multiple of 9. So the arms, 4.5 in the front, 4.5 in the back, 9. Legs are 9 on the front, 9 on the back, 18. The problem is, depending on the age group, those sizes vary, especially in kids because their head is so big. So one of the easier ways of figuring out burns on a pediatric patient is everyone's hand from their fingertips to their wrist crease is about 1% of their total body surface area. So if you look at that kid's hand and you say, okay, how many of that kid's hands would it take to cover that burn? It'll put you in the ballpark of how big that burn is. The formal way we do it is what's called a London Browder chart. Basically, at the hospital, somebody's figured out by age group the percentages, and we only count second and third degree burns. But what I will tell you about this is a moving target, meaning what I calculate on admission isn't always the same 12 hours later or 24 hours later. I'll give you an example. You may have a person who comes in and their whole anterior torso is red, 18%. The question is that redness going to go away in 24 hours, or is it slowly going to start to open up, and next thing you know, 12 hours from now, you swipe it and all the epidermis comes off? Well, now that's an 18% burn. That's, a significant burn that we would hospitalize somebody for. And I would say, whenever there's a question of is it going to open up, it's better to keep them and make sure, because if it does open up, then you can start the fluids on them and basically take it from there. But it's not uncommon for us to redo this once or twice after admission, because then you'll finally get the true either depth of injury once we operate or just how much actually peels away. The current fluid recommendations from the ABA for our 13 and up is 2 cc's per kilo per percent burn, and you just divide by 16. So it used to be, you calculate it, you divide by 2 and then divide by 8 because you're giving half over the first 8 hours. If you just divide by 16, it's just one less step. So for our children 12 and under, it's 3 mLs per kilo per percent burn. And then for children under 12, we run maintenance fluids on them because their body surface area, body mass is different than adults. And they also tend to get hypoglycemic. They don't regulate their sugars well, so we give D5. So typically what we do is we calculate our maintenance rate. We use the 4-2-1 rule. So 4 times the first 10 kilos, 2 times the second 10 kilos, 1 for each additional kilo. So if you have a 25 kilogram kid, you're going to run that at 65 cc's an hour, D5 LR. You don't titrate that at all. It just runs constant. What you titrate is when you calculate out that 3 mLs per kg per percent burn, that's what gets titrated up and down. So say the maintenance rate is 65 an hour and your fluid resuscitation rate is 250 cc's an hour. That 250 cc's an hour is what gets titrated up and down based on urine output and how the patient's doing, but the maintenance rate stays. When you're dealing with electrical injuries, because electricity can go anywhere in the body and do massive amounts of damage, we do 4 cc's per kilo, and that's because we're trying to get the urine output higher to try and flush out their kidneys and get all that toxic stuff out of their system if they've got rhabdo. Other studies we get in our secondary survey, so CBCs, lights, checking glucose levels for our kids, our diabetics, pregnancy tests, urine drug screen, chest x-rays, ABGs or carboxyhemoglobins if we think they have an inhalation injury, EKGs if they have an electrical injury, and then type and screen or type and cross if they've got associated trauma going on. As far as depth of injury goes, this is one where I think there's probably the most confusing one is second-degree burns because there's different depths depending on how deep it is in the dermis. Your dermis on your back is some of the thickest in the body, and your dermis on your eyelids is the thinnest. The same amount of heat and time in contact is a much different burn on your back than it is in your eyelids, where it could be a much deeper injury. Part of the reason why we resuscitate people within a burn, there's called zones of injuries. There's a zone of coagulation, which is basically the central part, which is burnt past the point of saving. There's nothing I can do that's going to change the course of that skin. There's a zone of stasis, which basically is an area around the zone of coagulation where perfusion is sluggish, and basically we're resuscitating. We're trying to get more perfusion to that area and salvage it. And then there's a zone of hyperemia, which is basically just red and reactive to the fact that you got burned. That zone of stasis that we're trying to save may not be a big area, but say it's the skin on your elbow or your knee where it's highly functional in how it bends. You want to try and preserve that. So, that's part of the reason why we're resuscitating patients. First-degree burns, sunburn. Everyone's seen one of those. It's painful. It typically doesn't peel. Usually if it peels, it's going to be 5 to 7 days later, and it's healed by the time it peels. Superficial second-degree burns. So if the top layer comes off, anytime the top layer comes off, it's a second-degree burn. What you want to see is that the dermis underneath is nice and pink and blanching. Like when you push on it, you should see cap refill. That's a superficial second-degree burn. The nice thing about that is it should heal within about 2 to 3 weeks and probably won't leave a scar. When you get into deeper second-degree burns, you're deeper into the dermis now, and it'll either get paler or more cherry red, and that's showing you that those are deeper areas. And usually it takes a couple days for it to demarcate, but those are more likely going to end up in the operating room needing debridement. If they're small areas, sometimes we'll treat those as outpatients, do antibiotic ointment, give it a couple weeks, see if it heals before we talk about a skin graft. But if they're bigger areas, they're going to get admitted for wound care. And then your third-degree burns, typically they're insensate. So when somebody comes in with a burn and says it doesn't hurt, that's not a good thing. It should hurt. If it's not hurting, it's usually deep. So you can see here, these pale white areas or cherry red areas, those are indicative of deeper second or third-degree burns. Fourth-degree burns, you're basically getting down to name structures, tendons, bones, muscle, that kind of stuff. As far as wound care goes, like we talked about, if you're just picking someone up and taking them to the burn center, or if you're in another facility, like here, coming to burn center, throw some clean sheets and some warm blankets on them. That's all you need to do. If you want to get into dressings, generally speaking, little fingertip blisters, we leave those alone. But if they start getting bigger than about 2 centimeters, or start getting bigger, baggy, we cut those off. The epidermis is dead. So we remove the blisters. We typically will do clean it, put on some sort of antibacterial later, like antibiotic ointment, Silvadene cream. They all work very well. If somebody is transferring patients to me, I like antibiotic ointment, and the reason being is that Silvadene cream, although it works very well, it leaves a film. So then when you see it, you're like, is that dead skin or is that the Silvadene? And then you got to scrape it off, which patients don't like. Antibiotic ointment is clear. So when you take the dressings down, you're like, oh, okay, this is what it is. But either one works. Typically, then we put on a non-stick layer, Telfa, Zeroform, Cutisarin, whatever you got. And then we usually wrap it up with some gauze. If an extremity, some Curlex works just fine. If you are putting dressings on a patient, one thing to remember, especially if you're resuscitating a patient and or there's going to be transport times, if you roll a Curlex on somebody's arm, and then, maybe it's 3-4 hours before you get to a burn center, all that edema sets in and then it swells and it may become a constrictive dressing. So roll it on loose and check it periodically to make sure nothing feels tight. Otherwise, clean sheet, warm blanket works just as well. All right, non-accidental trauma. So biggest thing I tell people is, does the story make sense? If you tell me the kid pulled a cup of coffee off the countertop and it looks like a curling iron burn, I'm sorry, you're going to have to tell me again how that happened because it doesn't make sense. And I tell people, if anybody has any suspicions, whether it be EMS, nursing, social work, ER doctor, burn surgeon, whoever, you can always call child services and let them screen just to make sure, because the reality is the next time could be the fatal one and we want to make sure we don't miss anything. Now, that being said, accidents do happen. It is a judgment call about, does this sound funny? And do I need to have somebody look at this? Some classic patterns of injury. So I think everyone knows what a curling iron would look like or a cigarette burn. There are some classic immersion patterns, so like cup of coffee. If you think about it, typically a cup of coffee pattern comes off the counter because kids reach up, splatters on the head, shoulders, kind of runs down, tapers off. That's a classic, yep, pull something off the countertop injury. When you see injuries like a pair of socks, that's usually an immersion injury. Because if you think about it, if the water was that hot that the kid put a foot into the bathtub, they wouldn't put the other one in. So typically somebody had them around the waist and lowered them down, and they have that sock pattern. The other one that is common, in addition to the sock pattern, is you see burns on the butt. And what that is somebody had their hand on their back, their hand under their knee, and lowered them down. The first thing that comes into contact with the water is the butt and the feet, and you have sparing of skin behind the knees and the back. That's a classic immersion pattern. Other thing to keep in mind too is that although this is prevalent in the peds population, it also happens in the senior citizen population. So, if you're picking someone up from a facility or from their home or something, again, probably want to get the story from the caregiver. How did this happen? Because it does happen from time to time with our senior citizen population. All right, resuscitation. This is just a little bit of the why behind what we do. When you get burns greater than about 20-25%, you get a whole body reaction, similar to getting stung by a bee and having a local reaction and having an anaphylactic reaction. So that's basically the threshold on why we start resuscitating. Basically, all your capillary beds start leaking when you get a burn better than 20-25%. Our goal is to give enough fluid to support end organ perfusion, but not more or less than that. When you under-resuscitate, you'll put them into renal failure and then domino effect. And since we've come up with these formulas that are size-based, weight-based formulas, we've gotten very good at not under-resuscitating patients. What we've gotten bad at is over-resuscitating patients. The theory that, hey, things are good, more is better, and what we found is that going the other way creates problems too. So you can end up with compartment syndrome, ARDS, you're basically flooding them with fluid. So about maybe around 2000 in the ABA, they came up with this term called fluid creep. And what it was they started looking at how much fluid we were giving patients in around 2000 for the same weight and same burn compared to what they were giving in the 70s. And they found they were giving, on average, a decent amount more fluid than what they were giving. So then it led to questions of, why is that? Some of it was, nowadays, one, we've gotten very good at critical care for burns, so people will stay alive. The issue is maybe we don't need to maximize all the numbers. When I was in training, they would say a patient might have good blood pressure, good urine output, and the CVP was 5, and they'd be like, oh, we got to get it up to 12, 15. You got them hooked up to a flow track. Oh, we got to get their stroke volume variation up to, normal. If they're doing good, their pressure's good, they're peeing good, you don't need to maximize numbers because you're just dumping more fluid into the patients. Now, there are scenarios where patients would require more fluid, so deeper burns. So if you get a 50%er that's mostly third degree, they're going to take more fluid than kind of partial thickness burn. If they have an inhalation injury, if you have an inhalation injury, it can really increase the amount of fluid they take. It causes a massive inflammatory effect in the lungs, so they can soak up more volume. If there's a delay in resuscitation, so if you don't get to them for a couple hours and they're behind, they can soak up a lot more fluid. So that's why it's important to start the fluids on the front end as soon as you come across those patients. So there are reasons too, but what I try and tell people is those fluids calculations, like if you're transporting, say you come here, you start them on the Parkland formula, and then you're going to be transporting. That calculation, that starting rate, that's just a starting rate to put you in the ballpark. Everything you do after that every hour is based on how is the patient doing. Hey, patient's urine output's better than expected. Okay, let's turn the fluids down a little bit, see what happens. Patient's not doing as good, turn them up, okay? I can tell you, I do this for a living, and I turn the fluids down from time to time, and I get it wrong, and the urine output drops off. I'm like, oh, back up in the fluids. But you have to be asking yourself every hour, can I turn it down? Because then you're going to save more, you're going to save the patient more fluid on the back end. So I think that's the big thing I try to press upon people is, every hour you should be asking, how's the patient doing? How's the pressure, urine output? Can we tweak things? I would also say that when you're transporting I see sometimes with EMS is that instead of tweaking the fluids, like, oh, hey, pressure's getting a little soft, urine output's a little low, let's turn the fluids up, we just tend to go to lever-fed, and I think that try the fluids first, and then if that's not doing, the pressures are still getting soft, okay, add in the lever-fed. If they're acutely hypotensive, then yes, give them some lever-fed, but try the fluid first and see what that gets you, because it may be that's all you need. So we talked a little bit about the fluid creep, fluid resuscitation, again, from the field to the trauma bay through your primary survey and your fluid formulas. So urine output, generally speaking, for an adult, half cc per kilo. So your 13-year-olds and up, half cc per kilo is plenty of urine output for those individuals. Younger children, it's going to be more like half to 1 cc. And if you're talking about an infant, you're talking about usually 1 to 2 cc's. And if you have a high voltage electrical injury with evidence of muscle breakdown, so if you have rhabdo and you have myoglobin in the urine, which gives their urine an amber tea color, we're basically running that formula and we're basically pumping those fluids up to try and get their urine output to look more clear, yellow, or clear. And basically you're clearing all those toxins out of their kidneys before it creates a problem with kidney failure. If you ever have to do escharotomies, this is how we do it. Basically, on an extremity, you go from an area that is not burned through the burn to an area that is not burned on the other side. And basically, you're just going into the fat. And if that doesn't do it, then we just go to the other side, medial and lateral, and release it on the other side. Usually, by the time you do both sides, it's fine. A chest, we have to do vertical and horizontal because of how the chest wall expands. So we have to release it. And when you do this release, it'll get easier to bag the patient, or if they're on a vent, the peak pressures will come down because it's easier for the vent to drive the breath in. And if we have to do a fasciotomy, we're basically using those same incisions. We're just going down deeper into the fascia. It is rare that you would have to do an escharotomy for a thermal injury at an outside facility before coming to a burn center. Usually that's something that over a couple hours starts to go that way, and you're like, okay, it's time to open it up. So I'll get patients in where we see them at first, we're like, okay, there's a circumferential burn. Okay, it's a little firm. We wait a couple hours, fluids go in. Okay, all right, it's getting a little tight. Okay, let's open it up. So that can take time. Sometimes it doesn't, just with elevating. Sometimes they do fine. They don't need the escharotomy. The caveat to that is high voltage electrical injuries. I've seen full-on compartment syndrome within an hour of a high voltage electrical injury. So that is something that may need to be done in an outside ER prior to transfer if the transport times are going to be a while, because it's similar to a MI or stroke, timeless tissue, and you got to open it up. But typically with just a thermal injury, you don't see that as often. It's a slower process as compared to electricity. This is abdominal compartment syndrome. So this is what happens when you give too much fluid. The problem with this is that when you get to this point, your mortality, regardless of age, comorbidities, anything, is probably about 80–90%. It's an independent predictor of mortality. And what happens is you're putting fluid into the patient. Fresh fluid is accumulating in places you don't want it, the belly, the lungs, extremities. As that pressure increases, it starts putting pressure on the renal vein and artery, and the urine output starts dropping off. And if you're not looking for it, you're basically thinking, oh, more fluid. And that's the wrong answer because it just increases pressure. We have to take them to the operating room, open up the belly, and basically relieve the pressure, and they'll start peeing again. The problem is you don't want to get to this point. So that's why, again, enough fluid to support end organ function, but not overdo it. All right, airway management. So classic signs of an inhalation injury. Burned face, singed nasal hairs, carbonaceous sputum, hoarseness. Now, that is a spectrum. So you're going to see a lot of people who are lighting their grill and it flashes and their face looks bad. And they may even have some blisters in their mouth, but it's rare that that heat gets down below the cords. Typically what causes the problem is all the chemical particulates and the smoke that they're breathing in. That's what really does damage in the lungs. So I've only seen maybe 1 or 2 instances where we probably got heat below the cords. I had a guy pinned one time in an industrial accident, was breathing in hot steam. I'll buy that. You can't get away from it. Or if you're in a house fire and you can't get away from the heat, yeah, you can get stuff down below your cords. But generally speaking, your upper airway does a really good job of thermal regulation as far as things that are hot or cold and basically warming it to or cooling it to normal temperatures. So you're going to see flash burns to the face. It's rare that a flash burn to the face causes an inhalation injury. The ones that scare me are on my radar. Anybody who's stuck in a confined space that can't get away from a fire, house fire, car fire, had to be extricated. Yeah, you're on my radar for you could have a serious inhalation injury. We see a lot of smoking on home oxygen. And it's rare that smoking on home oxygen causes an inhalation injury. That cannula goes up like instantaneously. What happens a lot of times with that crowd is it looks bad. They've got soot on their face, looks bad. and they come in, and a lot of times we reflexively put nasal cannulas back on them. And now their airways are all clogged up and their nasal passages are swollen. There may be some of that cannula melted in it. They can't breathe through it. So a lot of times what I'll tell, I'm talking to ERs, is put a face mask on them so they can breathe through their mouth. It's surprising how their SATs come up when you put a face mask on them, and or if they're a COPD, or if you got some time, like you don't need to emergently intubate them, give them a breathing treatment and see what happens. It's a lot of times that just calms them down and they're good. Now it's just a facial burn that needs to be, antibiotic treatment. And most of those facial burns that go on, as bad as they look, they go on to heal because the blood supply to the face is better than other parts of the body. It does a very good job of healing. Now, every once in a while, you will get a COPD or that does need to be intubated after smoking on home oxygen, but a lot of them get away with not getting intubated. And I tell people I never fault anybody for intubating a patient because we can always extubate them in a controlled circumstance in the ICU in a couple days. It's just the COPDs are a little bit harder to get off the ventilator, so give them a chance before you jump to intubation. The three ways in which inhalation injuries cause problems. So there's the heat that goes in, so you can have blisters in the mouth. You can have upper airway swelling, so above the cords from heat. That does happen, so that could potentially contribute to some stridor or hoarseness where you may, err on the side of intubating. The chemical particulates that go in, and basically what happens is you get the soot in your lungs, and what it does is it causes hyperemia. It stops the cilia that lines your lungs from helping to clear things. You get hypersecretion, so a lot of mucus formation. And then eventually what will happen over a couple of days is the lining of your lungs will start sloughing off like the burn and clogging your lungs up and going down and forming casts. The other thing is that a lot of the byproducts of things that burn around you produce carbon monoxide and cyanide. So everything in this room that would catch on fire will produce cyanide and carbon monoxide. And the issue is that carbon monoxide and cyanide inhibit the body's ability to utilize oxygen at a cellular level. So even though you've got oxygen in your system, your body's not using it. So in effect, you're suffocating. So you can have a pulse ox that reads 96%, but they're still not utilizing that oxygen that's in their system. So this is an algorithm that Dr. Sheridan, one of the guys at the Shrine in Boston, came up with. And basically, it's kind of just reiterates what we've talked about. Patient comes in, possibly an inhalation injury. These are the patients that you would want to put on 100% oxygen in case they have carbon monoxide. If you don't think they're have an inhalation injury, you don't have to put them on 100%. But if there's a suspicion of an inhalation injury, put them on 100% oxygen until you figure out what their carboxyhemoglobin levels are. And that's because that oxygen washes it out of their system. So anyway, bring them in, sit them up. If they're talking normally, they don't sound hoarse, you can sit them up, humidified oxygen, give them a yank hour, let them cough things up. And if they're doing fine as you serially examine them, then that's it. That's all you need to do, just serially exam. If things start to change, they start getting hoarse, stridorous, hey, I'm short of breath, don't just put the tube in. The reality is things are going to swell. So if you feel like it's going that way, put the tube in. It's easier to get it in at that time than it is to wait for swelling. And I would say, I would have a lower threshold for this in a pediatric patient because their airways are smaller. The same amount of edema in an adult patient as in a pediatric patient, it's going to be a lot worse off. Your typical adult trachea is maybe 8 millimeters, a peds is 4. So if you have 1 centimeter of additional edema in that airway, that's not much for an adult, but that's 25% in a peds patient, and their resistance goes through the roof. So in that scenario, you'd want to put a tube in a peds patient if there's any concern. Other thing with pediatric patients, we like cuff tubes, and the reason for that is if they develop ARDS and we have to use higher drive pressures down the road on the ventilator trying to get breaths into them, with a uncuffed tube, depending on how it fits that airway, depending on swelling, you basically, the vent tries driving it in and it blows out around the tube because you don't have the cuff there. So we like cuff tubes, and even exchanging a cuff tube in an ICU under controlled settings is scary in that population. When you're trying to exchange one of those a day or two later when they start developing ARDS from a lung injury. So ideally, if you don't have a cuff tube, fine, get the airway, but we're going to swap that out as soon as we can when they do hit the burn center because we want to put a cuff tube in them. Carbon monoxide, the way it works is its affinity for hemoglobin is 200 times out of oxygen. So basically it shifts your dissociation curve to the left, and you can't utilize the oxygen as well. Some symptoms that carbon monoxide causes. So you can have carbon monoxide levels in a person who doesn't smoke, 0 to 5, 0 to 10 for a smoker. Once you get over 10 to 20, they may complain of some headaches and confusion. Higher than that, you start getting into visual changes, hallucinations. At 60, level 60 plus, you can have cardiopulmonary arrest. We see a lot of patients that have drugs and alcohol on board or other things in their system that cause confusion, cause them to be combative. Don't discount this if they're being pulled out of a house fire. It's amazing how quickly they can come around if it's just carbon monoxide poisoning with a little oxygen. It'll basically counteract this. The way it works is the half-life of carbon monoxide on room air is 4 hours. On 100% oxygen, it's 40 to 60 minutes. So if their levels are 60, you put them on a non-rebreather at 100%, or if you intubate them at 100%, in an hour it'll be 30. In an hour after that, it'll be 15. So an hour on that oxygen, they may start coming around, start actually answering questions. They can go from attended to awake and alert within 2 hours with carbon monoxide poisoning. Cyanide poisoning requires a cyanic kit. Now, the way cyanide basically blocks your body's ability to utilize oxygen at the cellular level, and scenarios where I would suspect cyanide poisoning, so cyanide and poisoning and or carbon monoxide poisoning tend to run together. So patients being pulled out of a house fire, patient being pulled out of a car fire. And unfortunately, the cyanide test usually takes a day or two for the lab to come back. Carbon monoxide, you can either get a carboxyhemoglobin, or they do make finger probes that you can put on people that will give you a carboxyhemoglobin reading right then and there, so you can get that quick. But scenarios where I would suspect this is you pull someone out of a house fire, maybe it's an hour before they hit the ED, and EMS says the pressure was good on the way in, their SATs were 96%, we gave them a liter of fluid, their blood pressure was okay, we get them in the Tron Bay, we get labs on them, we get an ABG, and their base deficit's like -8, -10. Well, why? Everything you told me says they're perfusing. They've got their oxygen SATs were good, their pressure was good, their heart rate was good, you gave them fluids. Why are they that acidotic? Probably because of carbon monoxide or cyanide toxicity. And those are the ones where I would err on giving them a cyanic kit. The scenario fits. They were in an enclosed space where they couldn't get away from the fire. They were breathing that stuff in. Chances are their carbon monoxide levels will be high, and chances are their cyanide levels will be high. And those are the ones that I typically are going to say, just give them the cyanide kit. Cyanide, the hydroxycobalamin or cyanic kit is fairly well tolerated with patients. For an adult, it's a 5-gram dose. Basically, the kit is 5 grams, so you just give it. For peds, they don't make a peds kit. The dose is 70 milligrams per kilogram. So basically, our pharmacist usually has to mix it and then give it. And I will tell you, it looks like a cross between cranberry juice and grape juice. And when it comes out the Foley, it looks the same way, and it also starts coming through the skin. Like you'll see, you'll have sheets on a patient, you'll see sera staining on the sheets, and then it'll start getting a little red, and it's the cyanic kit coming out of everywhere. It stains everything. Takes a few days for it to go away. They do say that it messes with the lab work. Basically, because of the color of it, it throws off the spectrometer in the lab. I can't ever say I've seen labs after giving a cyanic kit where I'm like, oh, those are way off. That must be the cyanic kit. Usually they're still okay. But it apparently can do that. It also can cause some bradycardia and some hypertension, which is not necessarily a bad thing if they're already a little on the hypotensive side. All right, chemical burns. So there's 2 types of chemical burns, acids and bases. Of the 2, the bases are worse. Unfortunately, that's most of the stuff in your house, Drano, oven cleaner, things of this nature. And I will tell you that the sooner we get the chemicals off, the better the patients do. So if somebody called me up and said, hey, I spilled Drano on myself, should I come to the ER? I'd say, no, get in the shower for 30 minutes, then come to the ER, because the sooner you get that off, the better. The issue is acids, when they burn to a certain depth, and they burn themselves out as they mix with certain proteins in the skin. Bases liquefy. So the longer it sits there, the deeper it burns. It'll just keep going until you wash it off. So the longer it's there, the worse it is. The other thing to remember is first responders. Please, please, please put on protective equipment. You have no idea what that chemical is. You have no idea how fast it absorbs through the skin. You have no idea how toxic it is. So it's going to be something that can make you very sick very quickly. So protect yourselves when you're dealing with these patients. As far as irrigation goes, the goal is to irrigate down to the ground or irrigate down a drain. You don't want to put them in a bathtub. If it's a really potent chemical, you put them in a bathtub, you're just circulating contaminated water around the patient. You got to get it down to the floor. General recommendation for burns, for irrigating, 30 minutes, tap water. There's been nothing that's been shown to do better than that. Put them in a shower, get it off. Things to remember with large volume irrigation. You're also going to potentially get hypothermic depending on where you're doing it. So remember to try and keep them warm, wrap them up afterwards. We don't do anything different for dressings for chemical patients as compared to thermal patients. You know, same thing, clean, dry sheets. If you're going to do dressings, antibiotic ointment, nonstick layer, wrap them up. The big thing is just get the chemical off on the front end. There are a few caveats to chemicals. So we normally just irrigate. The reason we don't do neutralization is if you've ever mixed baking soda and vinegar together and seen the reaction that happens. If you have a very strong base and you try and neutralize it with an acid, you can get an exothermic reaction. So basically you're generating heat on top of the chemical burn, which you don't want. So that's why it's just irrigate. There are a few things like hydrofluoric acid, where after you rinse it off, it absorbs very quickly through the skin and it basically binds the calcium. So we use calcium gluconate gel, which helps to neutralize it, but that's usually after we irrigate gross contamination off the patient. But for everything else, it's basically just irrigate it. Other things too, if you're picking people up from a workplace, they should have something called a material safety data sheet, meaning every workplace should have a list of chemicals the employees are working with, and it should tell you exposures, if they get it on their skin, if they breathe it in, if they get it in their eyes, and what are the things you got to worry about. So that can help give you a roadmap of what to look for. If they don't have it, or if it's just someone's house, regional poison control has a very good catalog of what the chemicals are, what they do. So that's the other good resource to get a hold of, is poison control. All right, electrical burns. So this is another one where, again, make sure the scene is safe. You want to make sure that patient is not in contact with a live wire, because you'll be the second victim in a heartbeat. So scene safety on electrical burns. Electrical burns are arbitrarily broken up as high voltage or low voltage based on 1,000 volts. And basically what that has to do with, and there's no hard and fast data on this, but basically you need more voltage to try and penetrate the skin to go internal and do things, because one of the big resistors to electricity is your skin. How I think about it is, did it happen in a house or did it happen outside a house? In a house, I know it's going to be 110, 220, 240. Outside the house, I have no idea how much voltage is running through that line until I get a hold of the power company. So I just assume it's high voltage if it happens outside of a residential structure, and treat them as such. And that's going to kind of dictate what we do as far as, you know, do we admit them and observe them? Do we let them go home? But that's kind of how I break it up. Ways in which electricity does damage. So there's the true electrical current flowing through somebody. So, you know, electricity can go anywhere in your body and do anything it wants, and we have no predictive pattern as to why or where it's going to cause damage. And it can be small. So typically like direct current, which is going in a loop, basically tends to want to go in somewhere and out somewhere. So like if you touch something, you might see a small entry wound in the fingers. You might see something coming out between the web spaces and the toes because it's trying to go to ground. Alternating current, basically 60 cycles per second. So you can have one point of entry and not have an entry exit wound. You know, I've seen, and they can be small. So you have to really look to see where these are. So like, for instance, I've seen guys wear baseball caps, that little metal button right here. If you don't comb through their hair, you won't see it, but that could be the entry exit point. It can be that small and it can do massive amounts of damage. There's the electrical arc. So think about lightning arcing to the ground. You can get arc from a generator. Those arcs can generate temperatures in excess of 4,000 degrees. So that can light your clothes on fire. So in addition to the electrical injury you have, now you have a thermal injury on top of it. So it can be multi-pronged when you're dealing with electricity. As far as how electricity does damage, there are certain things that electricity will flow through easily and things that it won't flow through easily. Things that it goes through easily doesn't tend to do as much damage. When it hits an area where it doesn't, the body doesn't allow it to pass easily, it generates heat. So things like muscles and nerves and blood vessels allow current to flow pretty readily through it. Things like tendons, bone, fat, skin are a big resistor. So a lot of times when you're dealing with high voltage current, you'll see like the skin is charred bad. And a lot of places where we see a lot of damage are hands and forearms, feet and calves, because the cross-sectional area is small and it's densely packed with things like tendon and bone and fat and stuff that doesn't allow current transmission. When you're dealing with low voltage stuff like plugging a 110 into an outlet to charge your phone, usually the voltage isn't high enough to get through the skin for the most part. So you get little finger burns, but that's it. And those are the typical patients that we bring them into the ER, we do an EKG, we usually monitor them for about 4 hours on the monitor, everything checks out, you're gonna go home. And we know what the current is. Okay, it happened in a house, it was 110. You know, unless they've got an underlying like cardiac problem to begin with, we're gonna probably let them go home after we monitor them. High voltage injury or unknown injury, you're gonna spend the night with us. We're gonna do EKGs, monitor, we're gonna basically be doing compartment checks on you all night long to make sure nothing starts feeling like it's getting tight. And if you check out in the morning, then usually you can go home. If there's something else that comes up, then, you know, then we'll deal with it. Other things, electricity unfortunately does irreversible damage to blood vessels. So let me give you a scenario. You have a patient that comes in, high voltage electrical injury, they have no pulses at their wrist, their forearm is tight, needs a fasciotomy. You do the fasciotomy, now the forearm's soft, there's still no blood flow at the wrist. Why? Because chances are the electrical current that went through that arm damaged those blood vessels, and there's nothing you can do about it. You've done your job, you've opened up the compartment, but at this point, I have to basically wait and see what demarcates below the wrist and what's going to live and what's not going to live, because you can't do anything about it. So the big thing is identify compartment syndrome and treat it, but beyond that, there's some things you just can't salvage. So when you're coming up on scene, things to remember with electrical injuries. One, scene safety. Two, ATLS principles apply because they can spasm so hard, they can have fractures, they can get blown off their feet, hit their head. So ATLS. If they're in a cardiac arrhythmia, we use the ACLS guidelines. There is no separate thing for electrical current. Whatever arrhythmia they're in, it's ACLS. When you get to the hospital, that's when we're going to do our 12 lead. We're going to hook them up to the monitor. We're going to check everything, all the extremities for compartment syndrome. If it's high voltage, we're probably going to put a Foley in, see if they have any evidence of myoglobin in their urine, T-color, amber-colored urine, start them on fluids and get that rolling. All right, last one, frostbite. So, since it's that time of year, there are two types. There's several classification systems for frostbite. Here's all you need to know: superficial and deep. You got clear blisters, it's superficial. You got hemorrhagic blisters, it's deep. So if you were talking to me on the phone, that's all I need to know. The superficial one, probably going to be okay. The hemorrhagic one, different story. Things that are signs of good things, bad things when you're warming them up. So if you're warming up a patient and say the fingers are still purple, they're still insensate, not causing any real pain, that's not good. If they're warming up and they're getting pink and painful and more pliable, okay, that's a good thing. Big thing for, this comes from Alaskan field guidelines for rewarming patients. The big thing you want to know is when you warm them up, you have to be able to keep them warm. One of the worst things you can do for a frostbite injury is freeze thaw, back and forth. You want to warm them up and keep them warm. We typically use, they recommend circulating water at 37 to 39 degrees Celsius. I don't know anybody that has a bathtub to put them in and circulate water around. At best, what you can probably do is if you have a big sink, you can put a bucket in there. If it's one extremity, put the water, make sure it's the right temperature running, and you can then put their hand in the bucket as the water's overflowing into the sink. But short of that, you're talking warm blankets, bear huggers, turn the temperature up in the room. That's pretty much what everybody does. I have some extra things that I use for like esophageal warmers and other things that I use to try and warm them up faster if they're down and they're really cold. But that's probably the best people are going to do. Typically, we give them some ibuprofen because it helps attenuate some of the inflammatory pathways in the body. And then typically we want to keep them off their feet, dry, bulky dressings. And then the big thing is if you're giving them fluids, you want to make sure they're warm. And then beyond that, it's a question of once you get the patient warmed up to normal thermia, do they still have perfusion deficits in their extremities? So they're now normothermic, but you have no Doppler signals in your fingers. Those are potentially the candidates for TPA. Big thing that has happened in maybe the last 10, 15 years is we are now using TPA to try and open up blood vessels that have little microemboli from being frozen. Because you get little ice crystals in your cells, you get little microemboli in your fingers, and we're trying to open that back up again. So this is the recommendations from the ABA as far as treating frostbite, and kind of takeaways from this are rewarming, keep them warm. Early administration of thrombolytics. So ideally within 12 hours of rewarming, no later than 24. It hasn't been shown to do anything beyond that. So if you get them to the hospital, warm them up, that's when once they're warm and then they have perfusion deficits, then you can give the TPA. There's no real use for vascular imaging. They've been trying to figure out, is it worthwhile to get bone scans and things that show perfusion? The reality is you get them warmed up to normal temperature, core temperature, and they have perfusion deficits. Those are the ones, the fingers are still purple, toes are purple, no Doppler signals. Those are the ones that are candidates for TPA. There's two ways of giving it. One is IV and the other is intra-arterial catheter-directed TPA. The problem with catheter-directed is they got to lay flat, they got to for 24 hours. If you have multiple extremities, what are you going to do? Put a catheter in every extremity? The easier thing is there's a TPA loading dose that you can give, and then basically you run it over 6 hours, and that's it. You give it IV, and it hasn't necessarily been shown to be any better than the catheter-directed one. So for simplicity, that's what we do at the hospital, give them IV. Where this is important is in, and I try and work with, ER docs when I get calls about this, is trying to get it to get given in an outside facility. Where a lot of this came out of is out west. So you get people skiing in the backcountry and hiking, and they get lost and get frostbite, and they're 6 hours from or more from like a burn center. So if you can give that as they're being transported, time as tissue, it's more likely that they're going to do better. And what it's been shown to do is decrease either the level of amputation or decrease amputation outright by giving this stuff. That's the loading dose and the infusion rate. And then typically after we give it, we put them on usually a blood thinner. Once we've kind of opened up those blood vessels, we try and keep them thinned out for a few days. Contraindications, so that would be the same as the first things like stroke. So basically recent trauma, hemorrhage, abdominal surgeries, that kind of stuff, you're not going to give TPA. I think the bigger thing for us is deciding our patient population typically that we see down for frostbite usually have things like drugs and alcohol on board. And the question is, are they going to be cooperative? So out west, they've got skiers and hikers and people who are just out having a good time and are cooperative. We, on the other hand, that's not our patient population. So how do I figure out how to give it or not? Well, if I think they're on something and they're hallucinating and they're going to jump out of bed and hit the floor and they're on TPA, you're not getting TPA. Sorry. You got some alcohol in your system, but you're sobering up, you're cooperative. It's a judgment call. Like, okay, this guy's not 100% sober, but he is doing what we tell him to do. He's behaving. Okay, I'd probably give the TPA to that individual. So I think everyone's got to make that judgment call. This is just an example of what can be done. So top picture is on admission. You can see there's no flow. The bottom, this second picture here is basically after giving TPA after 4 days. You can see the flow is back opened up. Part of the reason why we don't remove these hemorrhagic blisters is because if you're giving TPA or a blood thinner and you swipe those blisters off, it's going to bleed and bleed and bleed. You just leave them alone. Usually we deal with the blisters a week or two down the road, but that's an example of healed up a couple weeks later. So basically you've gone from potentially losing all the fingers to salvaging all the fingers with TPA administration. And then when it comes to amputation, we still do the frostbite in January, amputate in July. Like, we let it demarcate. So we want to get to a point where what is pink and what is not, and that's where it's coming off. Some people have talked about, can we do things like imaging studies to figure out levels of amputation? The reality is it does fine, but for the most part, this dry eschar stays clean, doesn't get infected, and it'll just declare itself, and that's that. All right, questions? That's it for my lecture. Nothing? I like to leave them speechless. That's good. So hey, if you guys have any questions on this stuff after the fact, you can email me, or if you want to email him, you can email me. I'm happy to try and get you answers for it. But the reality is, like I said, for the most part with our burn patients, ABCD, same as trauma, you're going to be able to get through this stuff. And again, it looks scarier than it is. It's to me, in my mind, the bleeding trauma patient is more scary because there's less time to get it right than the burn patients, where there's more time to calculate fluids and get them wrapped up. So all right, well, thank you. Yep.
All right, guys. Hey, let's just take about 5-minute break real quick before we start on the rest of our reports. Thanks. 5-minute break. Guys, we're gonna get started. A great presentation by Dr. Gibbs. He's pretty cool to come from over St. B's come in. The guy that helped coordinate everything mentioned to me that he's got feelers out to other providers too for like peds and women's and anything we'd like to have them come and do. So that'd be kind of cool to have some pediatric or something like that come in. So next up's going to be Will. He's going to do his Union Hospital Clinton and Union Hospital Terre Haute STEMIs and stroke stuff.
Do so well with clickers. The big white button. All right. It does. All right, guys, so I've got a stroke and a STEMI from up north, and then a STEMI from Terre Haute. Our first case is a 70-year-old female, history of hypertension, GERD, migraine, hyperlipidemia. Family called 911 for a female patient with possible stroke. EMS was notified at 11:47, arrived on scene at 11:56, departed at 12:04, so on scene for 8 minutes. Stroke alert called at 12:05, arrived at UHC 12:18. For the run report, we've got a 70-year-old female sitting on the toilet at home. She had gotten out of the shower, was actually drying off when she completely lost her left side, collapsed to the floor. Was assisted up to the toilet by our son-in-law, and he was holding her upright when the crew arrived. Patient was awake, alert, GCS 15, pink, warm, dry, pupils are reactive, breath sounds clear, equal, no pedal edema. They did note left-sided facial drooping. The left arm was flaccid, speech slurred, garbled, but understandable. Patient's eyes were deviated to the right, turning her head to the right, neglecting her left side. Patient was lifted to the cot and secured. Stroke alert was called to Union Clinton. The monitor was showing AFib. This was a new finding for the patient. No history, not on any blood thinners. Saline lock was established in the left, lattice drawn finger stick of 157. I heard call before arrival, and she was taken directly to the CT scanner on arrival to the hospital. 12:22, they came in the doors. Stroke 1 was called, patient taken directly to CT. 12:35, teleneuro was paged. Consult began at 42. T and K administered at 54, so that was a door to needle of 32. Patient did go back to the CT for CTA, head and neck, to rule out LVO. The vituity neurologist read a blockage in the right MCA. So she was flown to St. Vincent's by a stat flight at 15:25. Cincinnati stroke scale, van were both charted on this patient. Good pre-notification from EMS, clear documentation of last known well and onset. Med order and T and K scanning were not completed in a timely manner. That's on the hospital. And this patient had a fantastic outcome prior to leaving. So the initial NIH stroke scale was 19. She was down to a 2 by the time she left. She still had a little bit of garbling in her speech, but she had regained the left side function before she left. Second case is a 37-year-old female, history of anxiety, depression, gout, hypertension. 911 call for female with chest pain and right shoulder pain. EMS notified at 13:45, arrived on scene at 13:50, departed at 14:12, STEMI alert called 14:24, arrived at Union Hospital Terre Haute 14:30. Upon arrival to the scene, they found a patient laying on her left side in bed complaining of chest pain and shoulder pain. Patient described the chest pain as a heaviness in the center of her chest, stated that the right arm felt numb. Patient states that she was nauseous. She sat up on the side of the bed without assistance and vomited bright yellow emesis. Patient states that this pain woke her up from her sleep. She had been out donating blood earlier that morning, didn't quite feel right, went home, tried to lay down, sleep it off, woke up with the pain. There was a scene delay as far as getting back out. They noted due to mounds of clothes and debris that they had to get around. And then she was too anxious to sit in the chair to go down the stairs, so they had to walk alongside of her to get her down. Complained of dizziness and feeling hot inside once she got into the ambulance, so some claustrophobia. Had open airways, speaking in full sentences, non-labored breathing, equal chest rise, GCS 15. When they got her on the monitor, she showed elevations in 2, 3, AVF, V4, 5, and 6, semi-suspected. IV established, Zofran given for the nausea, aspirin given for chest pain. Transported emergently to Union Hospital Terre Haute. En route, patient did calm down. Zofran helped with the nausea. They did put some oxygen on her to ease her breathing. STEMI alert was called by eBridge and iHern. Arrived at Terre Haute, no incident. Taken directly to room 3. So arrived in the facility at 1436, 1439 EKG showing inferior STEMI. 1458 arrived in cath lab. 1512 they were ballooned. So first medical contact of 88 minutes, door to balloon of 44. Fantastic times. Yeah, it had 2 blockages. It's right here. All you're seeing there is the wire crossing the first one. And then it's kind of hard to see up there, but it almost looks like there's air bubbles down lower where there's filling defect. So they did get the early notification on this, both eBridge and iHern. Unfortunately, they were unable to view the EKG prior to the patient's arrival, so they did have to get that second EKG to confirm. And again, first medical contact reperfusion of 88 minutes from up north. That's fantastic. For a Terre Haute case, we got a 46-year-old male. Anxiety, COPD, CHF, depression, hypertension, MI, and he has a defib. 911 was called for an inmate with chest pain on this one. EMS notified at 1:24, arrived on scene at 1:38, departed at 1:41. STEMI alert called at 1:44, arrived Terre Haute at 1:51. Dispatched to local prison in response to chest pain. Upon arrival, staff were wheeling the patient out to them, advised that the patient was having a heart attack. In this case, they were dead on. A&O ×4, skin warm, pale, diaphoretic, airway patent, respiration, tachypnic. Patient groaning, attempting to clutch at his chest. Advises that they had put an AED on the facility with no shock advised. Had a significant cardiac history, 24 stents previously. He was loaded into the ambulance, given 324 of aspirin. When they ran his EKG, had elevations 1, 2, AVF. Emergent transport was then initiated to Union EMR. They did have to unsecure the patient so they could actually work on it a little bit, get the IV established. Union was notified by iHern of STEMI activation. They did do the right-sided EKG. Thank you very much. Looking at that inferior, make sure that the right side is still working. And ER began to activate the cath lab shortly after arrival. Got in the doors at 1:54, 1:56, EKG showing inferior posterior STEMI, probable right-sided involvement. At 2:54, cath lab was activated. 324 vessel open, so first medical contact reperfusion of 105, door to balloon right at 90. This gentleman had already had a bypass graft, and you can see here where that graft had already been stented previously. So he does have a pretty rough cardiac history. They were able to restore flow into that bypass graft. Highlights on this one, again, checking that right-sided evaluation for your inferior MIs. Nitro was withheld due to the inferior STEMI, and he was hypotensive. EKG transmission prior to arrival. I wasn't able to find where that EKG had been scanned into the chart to verify whether it arrived prior to the patient or not. And the narrative on this one did a great job of painting the picture of the entire run. So good work there. Yeah. 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 Mm-hmm. Yeah. Right. This is everybody's. Yeah.
There wasn't many things. I was just curious.
Yeah.
To see if I looked at that.
It's all right.
Thank you very much. Thanks, Will. All right, guys, Beth is at home with flu A, so we're going to skip Beth's presentation. We're going to go straight into Tina from trauma. big white button.
Okay.
Good, Zoom.
Good morning. All right, we have two cases. The first one is a 49-year-old male. It was an MVA. 911 call came in at 1607, dispatch 1609. En route 1609. They were on scene at 1612, departed at 1633, and at Union 1642. Call to dispatch was 2 minutes. Dispatched en route was 0. En route to arrival was 3. They were on the scene for 21 minutes. Departure to arrival and AD was 9 minutes. Total call from 911 call to arrival was 35 minutes. The EMS report, they were dispatched to the scene of a single vehicle or motor vehicle accident, partial ejection. It was an SUV on its side. Down an embankment, they said it had rolled several times. Patient in the front seat, they were alert and oriented. Seatbelt was holding him in place. His head was partially out the window. There was severe damage to the vehicle. I couldn't see exactly how much, but they did document severe damage. Seatbelt was on. There was no airbag deployment. Took him 15 minutes to get him out. They monitored him during that time, and C-spine was held. His legs were pinned under the steering wheel, but he could move everything, but not able to move his left arm at the shoulder, just his elbow and down. So once they got him out of the SUV, they placed him in the C-color. Took 8 people to push him up the hill. He was a big guy. He had a scalp flap noted. His skull was showing. Was held in place with a bandage. They said bleeding was controlled, but there was active bleeding. Left upper shoulder was tender. They started 2 IVs, gave him normal saline. His vitals at that time was 104/58, pulse 104, rest 18, sat was 96, GCS was 15. Trauma alert was given and IHERN, gave him 1,500 cc fluid altogether. C-color and longboard. Pre-arrival note just said roll over, partially ejected, head out the window. So they called the initial activation, trauma alert activation as a level 2 at 1642. They upgraded it at 1647 to a level 1. Trauma surgeon arrived at 1716. So he met a level, they initially called a level 2, I think because of the rollover, which was fine, but he had active bleeding, and under that made it a level 1 as active bleeding from any source or uncontrolled bleeding. So that's why they upped it to level 1. He arrived at 1650, vitals at that time 97.9, pulse 100, rest 15, blood pressure 119/95. That was 94%, and they put him on 6 liters at that time. I'm not sure why. I didn't see where he desatted. He was awake, alert, and oriented on arrival. UCS was 15, still had the C-color on. He was complaining of head and neck pain, back pain. He had a large flap to laceration to the scalp. They said you could literally just pull it back and see his whole skull on the top. Had a small bruise on his knee. He couldn't lift his left upper extremity. When they tried it, just dropped to the bed. He was able to extend his wrist and make a fist, and that was it. VAS was negative. They put in a Foley, gave him warm blankets and fluids. They applied pressure dressing to the scalp. The wound was down to the skull. It was an approximate 20 centimeter degloving scalp laceration with active arterial bleeding. It was surgically repaired in the trauma bay by the trauma surgeon. They identified 5 arterial bleeders that were sutured, and they were still oozing, but it was greatly improved, much better control of the bleeding. The wound edges were approximated with staples. I couldn't find where it was documented how many staples, but I'm guessing a lot. There was one pretty decent sized piece of glass that they removed from under the flap. Estimated blood loss was 200 cc's. After returning from the CAT scan, because he went for his CAT scans, the x-rays, he desatted, and they had to intubate him, became hypotensive, blood pressure 79/57. They started 3rd IV. gave him 2 units of blood, and his blood pressure improved to 108/82. So his injuries, he had fractures of the anterior aspect of first, second ribs on the right and right scapular blade. He had extensive infiltrates to the right upper and mid lung fields were pulmonary contusions or interpulmonary hemorrhage. No pneumo. He had extensive soft tissue swelling around the anterior aspect of the first, second ribs. CT of the head showed the scalp laceration involved the right frontal, parietal, temporal, and occipital location. Triangular shape 4x4 foreign body, which was the glass they removed. CTA, the chest, abdomen, pelvis fractures, the first, second ribs on the right. Dislocation at the articulation, the first right rib with the sternum. Mild compression deformities with anterior wedging, T3, T5. Vertebral bodies, non-displaced fractures of the base spinous process of T4, infiltrates throughout the lung fields. And some degenerative disc disease. CT of the spine showed the comminuted misplaced or non-displaced fractures of the C4, C5, and the neck again shown C4, C5. Femur and pelvis, left femur and pelvis were negative. His labs white count was 20.2. Hemoglobin was 10.1. GAP 15, CO2 content 17. His ABGs on the vent, the pH was 7.250, PO2 259, base excess was -8. Bicarb 19.2, and SAT was 100%. So the diagnosis was MVC with major head injury, scalp degloving, laceration with active arterial hemorrhage, had C4, C5 fracture, suspected central cord syndrome with motor deficit of the left arm, and acute blood loss from the scalp hemorrhage, fractures of the first, second, right ribs, and bilateral pulmonary contusion. So he was transferred to Methodist via Lifeline at 21:38. Total ER time was greater than 120 minutes, was 4 hours, 48 minutes. And I don't have pictures. You know, I like pictures, but I don't have any of this. But it was quite impressive, they said. So. Anybody?
Thanks for presenting that, Tina.
Thank you.
It's a big, long case. This guy almost didn't have to go away, but just his mechanism of action there was enough for him actually to belong in a level 1 trauma center. He had a tremendous mechanism of action. And when you have first ribs, second ribs, diagonal scapular fracture, there was 2 cervical fractures, which probably were just in transverse processes. And maybe we're possibly keepable here. But then he's going to have pulmonary failure on the vent for 2 weeks in the ICU, and he's a big man. So this guy had kind of train wreck written over level 1 trauma center on him. Everything got taken care of, though. The degloving injury, the scalp, the arterial bleeders, they got taken care of. Sound like there was a half dozen of them. And he got stabilized 2 or 3 times there. Seemed like they were a little soft calling him a 2 to start with rather than a 1, but they changed their mind quickly and moved it up to a 1. But just that mechanism of action was almost a 1 right there. So it's a good case. I think did we hear how he did? I assume he did well.
I didn't hear anything from St. Vincent on him.
I would assume he did well. So anybody have any questions, anything with him? He basically was a good, solid, heavy-duty trauma case.
But it doesn't mean a lot to you guys. Anything greater than 6 is super critical for us in the world of trauma. Old boys at 80. Okay. The other thing that I wanted you to see was
What are you looking at?
there we go. So yes, he has arterial bleeding, but it became a distressing injury because we all ended up focusing on this head injury. His head was out the window. He scalped himself, right? So
Right.
did. But it became a distracting injury for us because he ended up, yeah. Got a C4, C5 fracture.
Uh,
He got, somewhere else, something else. We were concerned for.
The rib fractures. That was,
Rib fractures. He probably has that central cord syndrome too, because he doesn't really explain why his left upper extremity is so weak.
So when he come in, he complained about something to us that really was a flag. What was it? The arm. He couldn't move his arm, right?
Yeah. Oh yeah. 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 It was good that he'd been taken care of pretty well up to that time, because otherwise he, yeah, would have issues there.
yeah, because
Yes, this was bad, but our trauma guy was on it, but it became a distracting injury for us. So I'm pretty sure it's probably a distracting injury for you guys too, because old boy's head was hanging out the window.
Yeah.
So he went from kind of okay to not okay, right?
Yep.
Anything wrong. It just became a distracting injury. So this is a really good example of why you really have to look at the whole picture. Like his mechanism, right, was huge.
Right. He still could have had a belly or a pelvis on top of all this, and just, even had one more thing that really got him, but he didn't.
Anybody in here that had this? What's your?
it was after he came back from CT.
Yeah, so he had been bleeding, but we know he was bleeding, right? Because he was bleeding from his head. We know that because they identified that. I was hoping somebody was there. So that's kind of a long time, right? 15 minutes, yes, no? Help me, it's been 30 years since I've been in the field. For extrication, is that a long time or no? Not really, average? Okay. So, there's been a lot of time there, but it was like down, what was it? Down an embankment, and you said he was a big guy, right?
Mhm.
People getting
Pushed uphill by 8 people.
Yeah.
That's pretty good. If you ever watch that happen, that's pretty frustrating experience, watching somebody get extracted from the bottom of the hill.
Your point on scene, he could move from the elbow down. By the time he got to the hospital, he could only move his wrist. So there was progression there, So,
Was it because he was a big guy, he had an extended extrication, and he had a C4, C5 fracture. You can actually have airway compromise all the way down into the thoracic. So.
and that's okay, but I think, that's a good point is, with the distractions, I think at the beginning, they were thinking maybe the shoulder was dislocated. So, anyhow.
That would have been another good explanation for it. Yeah.
Yeah, yeah.
Probably the most common explanation. Yeah.
Right.
Yeah. Okay. Do you have one case or 2 cases, Tina?
Another one.
Okay. That was a good one.
That's why I had to ask.
Actually, to be honest with you, the total scene time, 21 minutes. That's absolutely correct. So, yeah, 15 minutes. I think the word extended is not the problem.
That's why I just wanted to clarify.
I think-
So it was an extended seat time because you couldn't get him out of there in the
Right.
10.
So 15 minutes is the word.
Yeah, because I've always remembered 30 minutes. It's actually 20.
So if we're at 20 minutes or above 20 minutes, we would appreciate some kind of definition in your narrative saying why you had extended.
We could look at that one and easily go, oh, they had to extricate him. There's 15 minutes for that.
When
So that
scene times get longer, she gives them to me, and I find areas that's probably why. And so that way we can justify it through the trauma registry. But,
Yeah, that,
yeah, no, you're good. You're right on. You're right.
Okay, we got one more and then we'll be done. The second case was a 35-year-old female. She was a golf cart accident. 911 call came in at 1831, dispatch at 1842. That was like, what, 11 minutes? I don't know for sure why, but I think it was, no, this one wasn't out of county. Anyhow, they were dispatched at 1842 en route 1845. On the scene at 1853, departed the scene at 1901 and was at Union ER at 1909. So times called dispatch was 11 minutes. Dispatched en route was 3, en route to arrival was 10. On-scene departure was 8 minutes. Departure to arrival in ER was 8 minutes. Total time 911 call to arrival was 40 minutes. So the call was dispatched for a 35-year-old female golf cart rollover accident. County Fire Rescue was already on site. On arrival, the patient was sitting on the side of the road, supine yelling that she was in pain. County Fire Rescue had placed a C-collar on the patient, and a bystander was providing stabilization to her ankle, her left ankle, which was an obvious open fracture. The patient's significant other was a passenger, was present on scene. He was uninjured. State's cart was going about 20 miles an hour when the rollover occurred. Patient was the driver at the time. Blood pressure was 142/112. GCS was 15. Respirations of SAT weren't documented. Pain was 10 out of 10. They gave her, started 2 IVs, gave her cefalozolin at 1904. Yay.
Hey, maybe that's how we need to handle these, is give them all these antibiotics in the field, because when they get to the ER, they sure as hell don't get them.
Yeah, yeah.
You didn't hear me say that, did you?
Well, I told him yay.
Okay.
A lot of
No, ER, defend yourself, but you've not been doing very well on IV antibiotics.
Zofran was given. Pain was 8 out of 10 after the second allotted. EMS continued, run continued. They did ankle wrap and applied SAM splint. Pedal pulses were checked and were present before and after splinting. They called Ihern with trauma alert, and she was taken to Union ER. Pre-arrival note said golf cart rollover, 20-25 miles an hour, open left ankle fracture. Level 2 trauma alert paged at 1906. So the ER arrival at 1913, temp was 96.1, pulse 106, rest 22, blood pressure 140/90, and that was 100% on Rumare. She had an obvious left lower extremity deformity. She had a C-collar on. They said she had frank deformity of the left lower extremity with an open fracture. She had PO pulses, good sensation. So she was a level 2 because she had an open fracture of a long bone. GCS was 15, skims of worm. She had road rash from left shin to left knee, road rash to left elbow, and tenderness on palpation to her elbow. FAST was negative. They gave her fentanyl and ketamine. She had a CT of the head, chest, abdomen, pelvis, and the C-spine. They were all negative. Left ankle, she had fracture, dislocation of the left ankle, comminuted fracture, the distal tibia, fibia, medialis, posterior dislocation of the ankle joint laterally when compared to the distal fibia. And there was anterior angulation. Let's see, and the x-ray pretty much showed the same thing. So she had an ankle reduction with conscious sedation. They splinted it. She had post-reduction x-ray with improved alignment. Diagnosis, open fracture, ankle fracture, dislocation of the ankle joint, MVA, and she's diabetic. I just do that in there because it always throws, any open fracture into tizzy, or has the potential to. She was admitted to the hospital with ortho consult, IV antibiotics, pain control, and PO after midnight. She was going to OR the next day, and she did go to OR for open reduction, internal fixation of the ankle fracture, and she had irrigation debridement of the skin, soft tissue, and removal of debris over the medial ankle. There was a 4-centimeter open area. Short splint was applied. PTOT was ordered, non-weight bearing, and she could discharge home when she passed therapy, and her pain was controlled. Case management was following. They got her a rolling walker, I think. Day 3, she was cleared by PTOT for discharge. Her pain was controlled, and she went home with her family. I do have pictures of this just because it was a really nice x-ray. So you can see in the first one, you can see the fracture up there. And then the second one is a nice picture of the fracture. The third one is after they had done the reduction. So as bad as that was, they did a decent job reducing it. And then these are pictures 2 weeks post-op of the hardware they put in. And it still just amazes me to put all that metal in your leg and you're like, oh my God, how can they walk? But it helps with the pain so much. And she was doing really good. Still using a walker, going to the doctor's office, but she was doing therapy and doing well.
Yeah, that all looks nice. That whole case looks pretty nice. She did not lose her pulse or anything. She had an open fracture, so that's complicated. I mean, it's dirty. She did get antibiotics. She continued to get antibiotics. She did have a sort of a line temporarily and put in a splint. And then they did do this operative reduction internal fixation the next day. I think I would have preferred her surgery on the trauma surgery service rather than go to the hospitalist. It's one organ system, but it was a little more decent mechanism of injury, and it was an open fracture. It was a little better fracture. Um, I'm sure the American College is going to argue with me that they could see benefits from it being on the surgical trauma service. So, what do you think, Jackie? Jackie out there?
Called in. So based off of how the 911 call came in.
Yeah, yeah. So, yeah, it's a good case. There's no problem. It's a good case from start to finish.
So I
Got
have a
it.
question for my EMS friends because we have another case that we're looking at. So, and I'm guessing now that answered my question. So it come in and then it was like 10 or 12 minutes before they dispatched. I don't even remember 11 minutes before.
Okay.
Okay.
So why would that be?
Well, I think that's something we have to address outside of this. The other thing I want to say is open fracture. Okay. So babies don't know this. Some of you that's been around a while knows this. It doesn't have to be poking through the skin. Okay. I'm hearing this when we're like, hey, did you consider antibiotics for that open fracture? And they're like, well, it wasn't an open fracture. An open fracture is any skin open within 6 inches of the fracture. So it doesn't have to be poking out.
Right, right. It just has to have the opportunity possibly to have barely poked it. It's
Because these are
yeah,
dirty wounds. This was a
right.
what golf cart? Okay,
Golf
so
cart, yeah. So it's not it's not clean by any means. It's not in the kitchen. It's out in out in the,
yeah,
yeah,
like Chris said, it can even be
farm
suspected.
yard.
Not going to hurt them. So, but it was a good case. It was well cared for. Obviously, it was really cool ortho pictures afterwards, but it was an open fracture. So kudos to whoever gave her those antibiotics. We don't see that very often. I know it is in your protocol. It's been there for a while, right? Yeah.
35 years.
So, if in doubt, don't worry about giving it.
Been
So.
there for 35 years in the emergency room within 24 hours too.
All right.
So yeah, we need to make sure and hit that one. So yeah. Any question? Oh, I'm gonna give somebody a point for the fast exam. Didn't necessarily need it, but if you're thinking about it, you should do it. And I mean, they did fall out of the golf cart and maybe got run over. Lord knows, but I think she needed it. It wasn't a real high risk for injury, but I think it was a good thing to do. And they have been harping on us about doing more fast exams. So I was glad to see a fast exam on this person too. That was good. ER gets pretty good points for this one.
Yeah. All right, guys. Thanks, Dr. Lynch. All right. Hey,
Thanks,
that's it.
Larry.
Up on the board. As you can see, there's the link and QR code. Fill out the information for me, please. Be sure and sign in. If you have any paperwork that you need me to sign, I'll be up here for a few minutes. Again, thanks for showing up. I truly appreciate it. Dr. Gibbs, I thought did a great job. I thought all of our presentations were good today. So that's it, guys. Thanks a lot.
Okay.
would the Fed Reserve now do that if the CFPB, if the hypothetical is the CFPB no longer exists, what would be the Fed's role right now with respect to technology firms?
We don't have jurisdiction over, we have jurisdiction over banks.
And that's it.
Market utilities.
So let me ask you this, because I know there's a number of Nevadans who file consumer reports of concerns about fraud and predators with the CFPB. The Fed Reserve doesn't receive those reports, correct? And you have no role when it comes to consumer protection, like the CFPB does, correct?
Unless you're a Fed member bank with $10 billion less in assets, then we have jurisdiction.
Right. So there is a gap. If the hypothetical is true, and what we're hearing that the CFPB is, there is a gap, what we're hearing in enforcement out there, particularly when it comes to consumer protection. That, would you say that's true?
Yes. Things that we don't.
Yeah.
Supervise.
And I think that's the concern we're all having right now, is this concern of when we're looking to streamline government. And listen, I'll be first to tell you, there's a lot of bloat. We need to streamline it. We need to address regulations and overreach. But there's a strategic way to do it, and not this burn down the house that is going to harm people across the country, including in my state, those Nevadans that are looking for some sort of enforcement around consumer protection law. So that's what you're hearing from many of us on our side of the aisle here.
Can I just very briefly add that we do